I'll go ahead and get us started. Good evening and welcome to Smilow Shares with Primary Care. Smilow Shares with Primary Care is a collaborative lecture series between our primary care clinicians here at Yale and our Smilow cancer care specialists. I'm Karen Brown, a primary care internist, and I will host this evening's talk with the help of Tracy Battaglia. This series highlights the primary care perspective in cancer care. Our primary care perspective is different. We're constantly providing advice to prevent cancer, testing to screen for cancer, testing for cancer, and fortunately less often finding a new cancer. But when we do, it's stressful and we want to get the handoffs right. And so those are the sorts of topics that we deal with. During this talk, please feel free to enter questions into the Q&A. I'll monitor it and pose questions to our speaker during or at the end of the talk when we try to save time for questions and a bit of an open conversation between our speakers. Tonight's topic is colorectal cancer prevention and screening. We have a terrific panel. I'll start by introducing Dr. Thejal Alam. Thejal is a board-certified family medicine physician. He received his medical degree from the New York Institute Technology College of Osteopathic Medicine, and he completed his family medicine residency at Northwell Health. He is a primary care physician, a busy primary care physician for Northeast Medical Group here at Yale in Rye Brook, New York. In his spare time, he's also an executive MPH candidate at the Yale School of Public Health, focusing on health policy. He serves as a co-director for another lecture series called Trust Your Gut on digestive health. He's very involved in what we call our care signature pathways, chairing and authoring several ambulatory pathways, and sitting on the primary care and infectious disease councils. He also recently joined the Connecticut Department of Health Outpatient Antibiotic Stewardship Committee. I'm going to turn over my virtual microphone to Tracy Battaglia, who joins me tonight as a co-host. She's the Associate Director of the Cancer Care Equity at our Yale Cancer Center. And she counts double because she's an internist and a professor in our section of general internal medicine. And she will introduce our other speakers. Tracy?
Thank you, Dr. Brown. It's really a pleasure to be here this evening with all of you and to introduce our esteemed panel. I'm excited to learn from this panel. Let me first, on behalf of the Cancer Center, introduce you to Dr. Thejal Srikumar. Dr. Srikumar is an assistant professor of medicine and medical oncology and hematology, where she cares for patients as part of the Center for Gastrointestinal Cancers at Smilow Cancer Hospital and Yale Cancer Center here in New Haven. She completed her undergraduate degree at Harvard and then received her medical degree from the University of Florida College of Medicine and completed her residency here at Yale, where she also served as chief resident. She went on to complete her medical oncology and hematology fellowship and chief year fellowship here at Yale, which at the time she obtained her executive master of public health degree in epidemiology and health informatics. We're very fortunate to have Dr. Srikumar's clinical and research efforts here centered around caring for young adults with gastrointestinal malignancies. And she's also quite passionate about medical education as she serves as our assistant program director for the Yale Medical Oncology Hematology Fellowship Program. Thank you for being here, Dr. Srikumar. I'm also here to introduce you to Dr. Xavier Llor, who received his MD degree from the University of Barcelona. Dr. Llor is trained in basic research and internal medicine at the University of Chicago, where he also completed his GI fellowship at the University of Illinois at Chicago. He complemented his training with a PhD degree in molecular biology from the University of Barcelona. He's a very active clinical gastroenterologist, where his research and clinical interests relate to gastrointestinal cancer prevention. He has an active basic science and translational research program, which focuses on several aspects of gastrointestinal cancer: hereditary and familial forms, screening and prevention, and disparities. He is a well-published investigator in the field and making seminal contributions to the fields of Lynch syndrome and other non-polyposis syndromic colorectal cancer cases. He holds many leadership positions nationally, most notably at the National Colorectal Cancer Roundtable and the National Comprehensive Cancer Network. So we're thrilled to have Dr. Llor here as a panelist. I'll pass it off to our panelists to get us started.
Thank you to both Karen and Tracy for those wonderful introductions, and thank you to the entire Smilow team for hosting us here tonight, and also thank you to our audience for joining us. Before we get started, I'll give a little bit of a background. So with that, colorectal cancer is a relatively common disease. In the United States, over 154,000 new cases of colon and rectal cancer are diagnosed annually. Colorectal cancer incidence and mortality rates vary markedly around the world. Globally, colorectal cancer is the third most diagnosed cancer in males and the second most in females, according to the World Health Organization. Tonight, we will go into greater detail about some clinical presentations in the primary care setting, when and how to screen, and what history and red flags to keep an eye out for to best support our patients. Next slide, please. So the United States Preventative Services Task Force recommends that adults age 45 to 75 be screened for colorectal cancer. Most people should begin screening for colorectal cancer as soon as after turning 45, then continue getting screened at regular intervals. However, you may need to be tested earlier than 45 or more often than this in certain clinical scenarios, some of which being inflammatory bowel disease, like Crohn's disease or ulcerative colitis, a personal or family history of colorectal cancer or colorectal polyps, or genetic syndromes such as familial adenomatous polyposis or hereditary non-polyposis colorectal cancer, Lynch syndrome. And with that, I would like to hand over to Xavier to discuss a little bit more about this.
Thank you, Prial. So starting first with colorectal cancer screening options. As we've heard over the last few years, the armamentarium for colorectal cancer screening has grown, and with the growth, complexity has come with that. And we'll really have to try to figure out what best suits our patients and how we handle that. This is a summary slide from the NCCN guidelines on colorectal cancer screening, and that shows on the left side, you see all the different modalities, starting with colonoscopy, which has been the traditional screening method in the US, then down the flexible sigmoidoscopy, CT colonography, then FOBT, and then now that mostly have been substituted by FIT, and then multi-target stool DNA test, the Cologuard test, and then you can see sensitivity and specificity for both colorectal cancer and then for advanced lesions. On the data on the Cologuard, that's going to be updated soon because Cologuard is releasing a new version of their test with a marked improved in specificity. So that's going to make an important difference. And over the last couple of years, we've seen an approval, FDA approval of two new methodologies. One of them is a multi-target stool RNA test that has similar performance to the newest test of the multi-target stool DNA test, maybe with the caveat that the failure rate is probably a little bit higher and likely related to the handling RNA instead of DNA, but something that overall didn't seem to have a significant impact. But again, it's a consideration. And finally, the blood-based cell-free DNA test that's come about again the last year, with the caveat that the sensitivity is definitely lower at this point than those stool tests that we mentioned before. And with that, we've come a little bit concerned about the fact of using this more in a generalized way, particularly if it's going to substitute the other options that probably are better at this point. But anyways, that's probably going to get better, and it's going to be another important tool that we'll be using for colorectal cancer screening. So stay tuned because this is really a moving target and there are more tests coming up, and hopefully we'll be able to altogether manage this new world of different options and be able to like make sure that at the end what we do is screen better and more patients.
100% agree, Xavier, especially from the primary care side, being able to advocate for our patients by giving them the options and being up to date on those guidelines is so important for us. So thank you again for that. And on that note, nice little segue. So for our healthcare system, we have something called the care signature pathways. Many of you may be familiar with this. What we do is essentially provide some clinical guidelines and clinical recommendations based off of expert consensus. Speaking of which, Xavier was one of the chairs for this department. Dr. Karen Brown was also part of this, so it's a collaborative effort between primary care experts and specialist experts, multidisciplinary as well. We sometimes have lab or imaging part of the team as well, depending on the pathway. So it's an excellent resource that we have. So with that, would we actually be able to skip forward to 3 more slides? Yes, this one right here. So this kind of gives you an impression of what these care pathways entail, essentially giving you guidance where or what ages we may want to screen, what red flags to look out for. So it also provides lots of great patient education tools as well. So if we have access to this within our healthcare system, I would recommend our colleagues to please take a look and give consideration. Okay, thank you. So with that, we'll go on to our case-based discussion of some colorectal cancer scenarios. And this first case will be based off of a real patient with slight modifications for teaching purposes. So this one, I'll read it, is a 57-year-old male with a past medical history of hyperlipidemia. It's diet controlled, prediabetes, gout, skin tags, and external hemorrhoids, who's presenting to established care with an annual physical after the prior PCP had left the practice. It has been over 18 months since the last examination. On chart review, during prior visit, patient had complained about blood in the toilet bowl and flares of hemorrhoids. During today's visit, this chief complaint still persists. Otherwise, patient is feeling at baseline and at relatively good health. Active problems include hemorrhoids. Medication-wise, nothing too outstanding. Colace, PRN for constipation, vitamin D, vitamin B12, and a multivitamin. Social history, the patient is a former smoker, did quit around 14 years ago, but does have a 10-pack year history. Habits-wise, social drinking, only about 1 to 2 shots of liquor per week. Occupation, no occupational hazard really, professional poker player, and no known family history. Next slide, please. So the patient only had a Cologuard done 3 years ago at this time, and also it was found to be negative at that time. However, patient has never had a formal colonoscopy. Patient had received a rectal exam during prior visit with the PCP. Stool guaiac was negative. Therefore, patient had declined a rectal exam on today's visit and wants hemorrhoid cream only. Patient is very apprehensive to colonoscopy and declines and reluctant for Cologuard again, as it was already negative. So next slide, please. So I guess there's a few of these questions that we'll discuss with our experts colleagues. This is a patient that I had actually encountered. So, and we, as primary care clinicians, may have patients that are reluctant to screening, especially if it was negative. There's some health literacy concerns as well. I remember with this patient. So let's start answering these questions and get some guidance from our experts. So one question we ask as a primary care clinician, what are the next steps? So Xavier, what would you say there?
Sure. So I think the clear message here is when we have heard from our patient that there was a red blood per rectum, we are no longer in the screening realm. And so forget about doing more fit tests or other things. And I've just seen a patient today who has been describing, just today in my clinic, just describing bright red blood per rectum for a year. And the PCP did order a fit test. And it's like, what's the purpose? We have gross blood. We don't need to look for occult blood. We already know. So that takes us to a different level. That takes us to a diagnostic level. So forget about anything that applies to screening. That's no longer applied to this patient, basically. In terms of the if it was appropriate for the patient to be screened with Cologuard, that was 3 years ago. So he would be due for next one because it's been approved every 3 years. So at that time, the patient had no family history of colorectal cancer. And therefore, if there's no family history of colorectal cancer, all these options, all guidelines seem to agree that all these options are reasonable, including the Cologuard every 3 years. Now, the patient is a smoker and he's a professional player, so he may actually smoke more than what we think, actually. So, and that increases risk. Clearly, alcohol does, obesity, lack of physical exercise, those do increase risk, and we may have some here. The issue, though, is that in the guidelines, we really have not separated that increased risk from family history risk. So family history calls for colonoscopy. No family history or other factors would call for either one of these options. But I think in the future, we may have to think about how these factors that we're mentioning here do change the risk and how do we incorporate them in our decision-making about what we suggest potentially for screening. But again, we are beyond screening at this point, but we're just talking about the treatment of the hemorrhoid. At this point, what we really have to do is just look what's going on. And if there are hemorrhoids, we'll treat the hemorrhoids, but first we need to figure out what's going on.
Absolutely. And I love everything that you said. And one of the most take-home points there is we've gone from the realm of screening to diagnostic now, and being able to communicate that, especially with kindness and grace, especially to a patient that may be a little more reserved and hesitant to any type of procedure in the first place, is very important. So I love everything that you said there. Thank you. And then with that, would we be able to go to the next slide, please? Thank you. And so what happened next? This patient was referred to a colorectal surgeon. At this visit, the patient had a rectal exam, which demonstrated an ulcerating rectal mass that extended from the dentate line to 8 centimeters above the anal verge. Arrangements were made immediately to have the patient have an urgent colonoscopy. As expected, the biopsy was consistent with invasive adenocarcinoma. And with that, we'd like to give this next slide over to Thejal, please.
Thank you so much. So I know this talk is focusing more on colorectal cancer screening and prevention, but I thought it would be helpful to do a big picture overview of what happens when that cancer diagnosis is confirmed. So the first thing that we always want to know is, what is the stage of the cancer? The staging of colorectal cancer is done by the American Joint Committee on Cancer, the AJCC-based recommendations, which is on the TNM staging system. The T stands for tumor, or the depth of invasion into the wall of the colon or the rectum. N stands for lymph nodes, or the number of lymph nodes that are involved locoregionally. And M stands for metastasis, whether or not there's any distant sites of disease involvement, for example, in the lung or the liver. And by combining these three components, we come up with a stage from 1 to 4, 1 being the lowest stage and 4 being the most aggressive, the highest stage. Staging not only helps us determine how aggressive the cancer is, but it really does guide what our treatment options are. Now, I should say that this is our staging system as of June 3rd of 2025. But just this past weekend, we had our major oncology conference, and there are some new proposed changes to this staging system, which might incorporate other elements such as tumor deposits and other factors of the biology, which may help us better predict how our patients will do based on their stage. But at this moment in time, this is what we use for our staging. Now, when someone has that confirmation of cancer on the biopsy, there are a few more pieces of information that we need to determine all of that staging information and also to help us guide what the next steps are. From the colonoscopy, that biopsy will confirm the pathology, but we actually send more testing from that pathology to characterize something that we call mismatch repair proteins. And I put an asterisk there because I want to come back to that. I'll put a pin in it and I'll come back to that. But that can actually have a lot of prognostic and treatment implications for our patients. In addition to the colonoscopy, we get CT scans of the chest, the abdomen, and the pelvis to evaluate for distant disease. And we get labs, including not only your basic labs, such as the complete blood count and the comprehensive metabolic panel, but we also will send what we call a CEA, which is a tumor marker, or also known as carcinoembryonic antigen, which is a protein that the cancer cells make and give us a sense of what the activity might be from the cancer. Now, for rectal cancer specifically, we also want to get an MRI of the pelvis. So if you think that the patient just has a colon cancer, meaning, from the cecum through the sigmoid or rectosigmoid, colonoscopy, CT scans, and the labs should be sufficient. But this is a key point. We treat rectal cancer differently than how we treat colon cancer, and we need more information. So for these patients, we get the MRI, and I'll circle back to that too. I just want to make a note that we don't typically or routinely get PET scans on our patients unless there's something concerning from our CT scan that would prompt us to do so. From getting all of this information, we want to answer two main questions. Number one, is this a localized disease or is it metastatic? And number two, is it colon or is it rectal? We'll return to our case now to get some of those pieces of information, and then we'll circle back to what happens next.
Excellent. And I really love your two main questions because that's really the two main questions that a lot of our patients ask us, right? Most patients know the terminology metastatic now, so they really want to know, is it local or is it metastatic versus the clinical pearl that you pointed towards, colon versus rectal from our clinical perspective. That's important for us to know as well. So going back to our case again, the staging CAT scan showed no evidence of distant metastasis for this patient. Rectal MRI suggested tumor was T3 or possibly T4 rectal tumor with a suspicious mesorectal lymph node. The tumor also appeared to be extending to the anal sphincter. Clinically, he was staged at T3, 4, and 1. PET scan showed no distant metastasis. Next slide, please.
Thank you. Yeah, so before I go on to the next slide, I'll just make a note here. So as I had mentioned, so we looked at the T stage and the N stage here. So with the T stage, it goes from 1 to 4 in terms of the depth of invasion. So having both the deeper invasion as well as nodal involvement means that he's what we call locally advanced. There's no distant disease, but it's also not necessarily the smallest tumor either. He's kind of in that middle road. So in terms of his next steps in treatment, as I mentioned, we treat colon cancer different than how we treat rectal cancer. And to give you a big picture overview, when someone has a non-metastatic colon cancer, typically the standard of care is to take them for surgical resection up front, and then depending on the final stage and the features of the pathology from the surgical resection specimen, that will help us determine whether or not they need any more treatment after the surgery, such as chemotherapy. In contrast, for rectal cancer, we've actually moved a lot of that other treatment up front before surgery. And we call that treatment strategy total neoadjuvant therapy, or TNT. The more recent studies have shown that doing both chemotherapy and chemoradiation before surgery can actually not only decrease the shrink the tumor and decrease the size of it before the surgery to help decrease the morbidity of a surgery and decrease the chances of needing something like a permanent ostomy. But moving all of this treatment up front has actually also shown to have a benefit for overall survival. So typically these patients will have chemotherapy, chemoradiation, and then go to surgery. But what we're also finding is that we might actually be curing some of these patients with chemotherapy and chemoradiation alone. This is a small subset of patients, and we're still trying to figure out who that is. But we are doing a lot of work in studying the watch and wait strategy. So treating with chemo and chemoradiation, and then delaying surgery and just following with scans and scopes very closely to see whether or not there's a recurrence of this disease. So let's circle back with our patient and see what happened with him. So our patient did begin this total neoadjuvant therapy, or TNT strategy, starting with chemoradiation, meaning that while he was getting radiation doses, he was also taking a chemotherapy pill called Xeloda. When he finished the radiation, they got some scans which showed that he had a good response, and they moved to that next part of the TNT strategy, which is the chemotherapy. He received our standard chemotherapy regimen, which is called FOLFOX, and I won't get into more details about that right now. But after completing both of those components, his PET scans showed that he had no residual disease. He got MRIs as well, and this continued to show that he had an excellent response to the TNT. And based on discussing with the oncologists and the colorectal surgeons, they decided to proceed with this watch and wait strategy, with proceeding without surgery and having close surveillance. So first, as of right now, surveillance for colorectal cancer upon completing curative intent treatment is following for 5 years with physical exams and H&Ps, as well as labs, imaging, and endoscopies as well. There's just one more point that I want to make, and this is going back to the asterisks that I had discussed about earlier, and that's about the role of immunotherapy in localized and locally advanced rectal cancer. So you might have seen these major articles come out in the New York Times and other news sources showing some dramatic responses that we've seen for a subset of patients who have rectal cancer that are deficient in what we call mismatch repair proteins. This means that they have more DNA damage in their cancers, and therefore they might be more likely to respond to an immunotherapy-based approach. And there was this really remarkable trial that came out that showed that of the 49 patients who had rectal cancer with this mismatch repair protein deficiency, they all had a clinical complete response to the immunotherapy alone. And that is without having any chemotherapy, any radiation, or any surgery to remove their initial rectal cancer tumor. So I think that this has been a really exciting finding and is just a taste of what's next to come. But this comes back to the fact that on our initial diagnosis of rectal cancer, we want to get that information to know whether or not they might be a candidate for immunotherapy.
Excellent points, Thejal, and thank you so much. And just to gently wrap up this case, some key points again: do not dismiss mild rectal bleeding, needs close follow-up. Again, this is where we're transitioning from just screening to diagnostic, right? Ensure patients are screened at adequate intervals. Thankfully, this patient was. But again, we need to change our modality to diagnostic. Collaborate with our specialist colleagues if there are suspicious findings or history. And early detection of colorectal cancer is key for treatment options and survival. Okay, and with that, we'll move on to our next case, please. So case 2 will be based more so on a suspicious family history. So here we have a 25-year-old female with no significant past medical history, except mild GERD controlled, presents for a routine physical appointment. As far as active problems, none. Medication-wise, PPI, PRN. No social history, no habits, smoking or alcohol. Occupational-wise, teacher. But we do see there's a family history of multiple colonic polyps in mother diagnosed at age 40. So at this point, some questions, if we could go to the next slide, please, is What are some outstanding parts from our history that are standing out to us? So Xavier, I'd like to hand off to you for this, please.
Yeah, I think the first thing that we like to say is that we gastroenterology should be a better job many times at saying polyps and how many polyps we find. We often describe multiple, and multiple for everyone may mean a different number. So really, it's not the same to have seen 7 polyps, which for someone can be multiple over the years, versus 25 polyps. So we really have to be much more specific. It would be important because our patient really has not had anything. It's all based on family history. It would be important to know that did mom have also colorectal cancer, just polyps, how many and all that? Did she have genetic testing? And key questions is again is like how many polyps, what type of polyps, were there some of them advanced, was the patient young at or mother young at diagnosis of those polyps, and again did she have genetic testing? Really getting information from mom may be very, very important on how we address next steps for this patient. If we're looking at someone who's developed at least 10, 15 adenomas or other types of polyps, then we really have to rule out a hereditary condition. Now we have a list of genes that have been associated, and beyond the very first one described, like which was APC. Now we have a variety of them, and some of them are inherited in an autosomal recessive manner. So you do need 2 copies of a mutated gene, and in that case, mom and dad usually won't have polyposis and cancer. So it may seem like it skipped generations. So important that we may have these situations with the generation just above having no polyposis, no colorectal cancer history at all. So again, we do have many more situations that are not the typical one that are associated with an autosomal dominant pattern. And also there are some de novo mutations in APC, up to 25%. So may have no family history at all, and all of a sudden, here we have a new polyposis case. If we can move on to next one. Besides those genetic ones, and I would skip the CPU one, we can, it's important also to notice about the potential prior history of chemotherapy and or radiation therapy, particularly during childhood and young adulthood. And that's been associated with what we call therapy-associated polyposis, which often is a kind of mixed pattern of adenomas and serrated polyps. So important to ask for that information. Next one is serrated polyposis syndrome. Most of the time, not associated with known genetic conditions, and this is more based on clinical criteria, but it does have implications in terms of cancer risk for the patients, but also for first-degree family members. So it's important that we understand what types of polyps there are and make sure is it a serrated polyposis or not. And going back to the first scenario, CPUE, that's colonic polyposis of unknown etiology, and we call those, once we've really seen an individual with polyposis with really no evidence of any genetic mutations in the genes that are commonly associated with polyposis and colorectal cancer. In all those cases too, family members do have a higher risk. So it is important that we kind of label these cases as appropriate as possible, because it does have implications not only for our patients, but for family members. So important to gather all that information if we want to understand better how to address the patient that we're talking about. And very, very important, and I think that skips so many of us, which is that even if there are not that many polyps, but if there was an advanced polyp, and what we call advanced is having an adenoma that's larger than 1 centimeter, adenoma with high-grade dysplasia, or tubulobilous adenoma, traditional serrated adenoma, or advanced sessile serrated polyps. All those ones, just having a first-degree relative who has had at least one of those puts us at a higher risk, and actually guidelines are calling for starting colorectal cancer screening at an earlier age, at age 40, or whenever the diagnosis was made in that family member. So that's how important it is that we know, even if our family member has got just 2 polyps and it's like, okay, well, big deal. Well, no, actually it can have implications on how we approach screening for our family members. So very, very important, number one, as physicians, to provide that information to our patients. and make them understand that that has implications for their relatives.
And then thank you so much, Xavier. As you're saying that, I was writing down notes as well. I feel like such an important key clinical pearl that you shared right there was not to miss those high-risk polyps. Again, we're seeing colorectal cancer and polyps much earlier in younger patients. So not dismissing just polyps in the family is very important. So in this case, getting a lot more history from the patient if they can share it, like it would be so vital and important. And then from the primary care side, I guess what I would want to ask our specialist colleagues is, how would we want to go about managing this patient? Like after we get like a more thorough history, would we refer them to our GI colleagues or want to touch base and coordinate with our genetic colleagues? Where would you recommend?
Yeah, I think definitely when we get that information from mom, that would really help us understand.
Mm.
If we do have a suspicion that mom can have a genetic syndrome, the appropriate thing would be seeing if mom could actually have that assessment because she
Mm.
shown that. I think that'd be number one. If at the end what we have is mom had several polyps, none of them advanced or whatever, we can take another approach. So really having that information will make a difference. And again, if we do think it could be genetic and does need to be ruled out that case, always try to get mom because she's the affected one. If there's no possibility, then we could definitely test her. And nowadays panel testing allows for testing of all the genes that we were showing here with a single test. So something that's relatively easy to do.
Absolutely. We oftentimes get partial history and fragmented history sometimes, and we may end up having to test our actual patients. Well, thank you again for your clinical insights. With that, I think we'll move on to case number 3. And with that, this one will be more so an early onset colorectal cancer. So I'll read this as well. We have a 39-year-old female with no significant past medical history except iron deficiency anemia and IBS who presents to her PCP for a routine physical appointment. Active problems-wise, she has iron deficiency anemia, menorrhagia, and IBS. Medication-wise, takes an iron supplement, oral contraceptive pill. Social history-wise, is a single mother of 2 young children. Habits-wise, never a smoker, denies alcohol as well. Occupational-wise, is a waitress, and family history, no significant family history. Continuing on review of systems, she reports over the last 8 months feeling more tired, and her IBS symptoms of bloating and diarrhea are worse, which she attributes to work-related stress. Labs-wise, she shows a hemoglobin of 9 down from 11. Iron studies show persistent iron deficiency. She has not been taking iron because she feels it makes her abdominal symptoms worse. Lab somewhat improved after IV iron repletion, but her symptoms continued to get worse and she was referred to GI. Colonoscopy was done, which showed a sigmoid mass, and biopsy showed adenocarcinoma. So at this point, what parts of our history is standing out? What are some special considerations for young adults who are diagnosed with cancer? And with that, I'd like to hand it over to Thejal, please.
Yeah, thank you so much. I think this is one of our greatest fears is that we're seeing younger and younger people being diagnosed with not only colorectal cancer, but other cancer types as well every single day. And this is, based on a patient who I've seen recently and a story that we're hearing over and over again. Someone who was otherwise healthy, has no family history, really not much in terms of risk factors, and they had been doing well until they weren't. And they come to this complete shock of getting a diagnosis of cancer at such a young age. So I think that the fact that we're seeing these trends and what we'll be talking about more is when you are having these unexplained and these persistent symptoms, even in our younger and healthier patients, we need to be acting on them. We need to be picking them up, and we need to get further evaluation promptly. So, as I mentioned, we've been seeing data over and over again, and you've probably read in the news that we're seeing rising rates and increasing incidence of what we term as early onset colorectal cancer. When I say the term early onset, I'm specifically referring to adults who are diagnosed under the age of 49, although that's not a strict definition. And as this graph depicts, not only are we seeing an increasing incidence, but we're also seeing that while mortality had been decreasing for a very long time, we then saw the mortality in this young adult population plateau, and now actually looks like it's starting to increase. I think one of our biggest questions is, why is this happening? And we don't have a great explanation. The reality is that it's probably multiple different factors that are interacting. It might be, the fact that we are having increasing rates of obesity and sedentary lifestyle. There's maybe something in the environment, what we're eating, what we're drinking, something that we're exposed to, all of these things that might be changing our gut microbiome and may lead to more of an inflammatory phenotype, which might be increasing our chances of cancer. But we don't have any sort of slam dunk explanation. And there's a lot of research that's going on in trying to figure this out. Now, what's, I think, challenging not only about the fact that we're getting the diagnosis of cancer in these younger people, but oftentimes we're catching them late. We're seeing young people present with advanced disease by the time that they're diagnosed. Some of it might be the fact that the biology of the cancer itself might be a little bit more aggressive, but there are a lot of other factors as well. There are factors related to the patients themselves. They might be ignoring symptoms they have. They might think, oh, I'm healthy otherwise. I'm just not feeling great right now. And so that might mean that they are not looking for care. A lot of young people don't have primary care doctors. And so by the time something is wrong, it takes them a long time to actually get in to see someone. There's also a lot of fear around this diagnosis, some embarrassment as well. There's also factors that might be related to the physicians that lead to the delay. They might miss symptoms, or they might attribute some of the symptoms to other more common diagnoses. A lot of these presenting symptoms can be vague. It's not, most of the time, it's not clear. And this might mean that there are delayed referrals and further examination. And then ultimately, there are a lot of system-related delays, limited resources in terms of providers, particularly in rural areas. The appointments are delayed. We're needing more and more help to take care of this population, but we just aren't able to meet it with the resources that we have available to us. Now, when a young adult is diagnosed with colorectal cancer, there are some unique things to consider that may not be necessarily as much in the forefront in our older patients. For example, this young woman, she might still be wanting to have more children. So fertility is a consideration. And how do the treatment options that we have for colorectal cancer relate to that and impact that? There are unique family dynamics. This young adult population oftentimes will have young children, toddlers. They might also be taking care of their elderly parents as well. Sometimes they're the primary breadwinners in the family in terms of their career. They might be the only one in their family who is making money. And so they may not be able to be taking the time off to actually get their treatments. They also might feel more isolated because other people who are their same age aren't dealing with these serious diagnoses. So that's even more of a psychosocial stress on them. And they're more likely to have a genetic reason for having their colorectal cancer diagnosed, which also has its own implications. And so I think for all of these reasons, there's a real opportunity here for our oncologists to partner with primary care who know these patients the best and have followed them for much longer than the oncologist has to work through the holistic picture. At Yale, we've started an early onset cancer program to do just this and to help to address all of these issues in addition to their cancer care specifically.
And then just to share a little bit, like I love those unique considerations that you spoke about, Thejal. It's very challenging with such a young diagnosis, and that's really where our primary care clinicians can be that bridge with our oncology specialists and be there for that holistic care, holistic approach. So again, really, really important. Going back to the case now, the patient was diagnosed with stage 3 sigmoid colon cancer, and she successfully underwent treatment with surgery and adjuvant chemotherapy. She followed with oncology for 5 years without evidence of disease recurrence, but has ongoing challenges.
So, as I mentioned earlier, surveillance for colorectal cancer per our national guidelines is recommended to follow for 5 years. But the buck doesn't stop there. The impacts of having a cancer diagnosis, both physically, but also mentally, emotionally, far outlast that 5-year time mark. There are multiple considerations that should be thought about when the care of this patient shifts more primarily or almost completely back to the primary care doctor at that 5-year time point. It's not only the physical consideration. So there might be multiple things to consider in terms of the physical aspect of it. Maybe they have a permanent ostomy. Maybe they have permanent neuropathy from the chemotherapy they had, or they might be at higher risk for another cancer because of the chemo they had. They might look different. They might feel different. They might have fertility impact. There's countless things physically, but it goes beyond that too. Psychologically, there's trauma from having the diagnosis in the first place. And we hear from our patients that sometimes when the 5-year mark is done, they sometimes feel forgotten about. But the truth is that experience that they have is going to shape them for the rest of their lives. And again, this may have longer term impacts in their social life in general as well. Maybe they need accommodations at work now. Maybe they had to interrupt their education. It's certainly impacted the relationships of their friends and family around them. So we have to be thinking about all of these things for long into the future when taking care of all of our patients, but in particular for our young adults who do have that lead time and that long runway ahead of them beyond their cancer diagnosis.
100% echo everything that you're saying. And then just a few key discussion points. Colorectal cancer incidence is increasing in young adults less than age 50 years old, even with those without clear risk factors or family history. And vigilance is needed to diagnose early. So getting a thorough history and not dismissing vague symptoms in young adults is very important for us from the primary care side. Oncology and primary care can partner to help provide holistic care to patients. And again, especially that aftercare, right? So that patient doesn't feel forgotten and are being followed through afterwards. And then with that, I think I was going to hand over to Thejal again.
Yeah. So Dr. Llor has already brought this up, but the question is what's next? What's happening now, and where are we looking for in the future? And I think that's where these novel technologies, such as the blood-based testing that was already discussed, has a lot of promise and a lot of excitement. The idea that someone can just get a blood test at the same time as they get all their other labs and have that be a part of their colon cancer screening, as well as other cancer screenings eventually, is really exciting and might help to overcome some of those barriers that we are facing from a systematic standpoint for our patients. But as was already addressed, our current technology is limited. So I think there's a lot more that is undergoing in terms of research right now and a lot more to look forward to in the future.
Excellent. And then with that, we'd like to share a few final key points to take away from this lecture. One being consider all types of screening options. If we think back to our first patient, they were appropriately screened with Cologuard. They were due for another Cologuard because they were at around the 3-year mark, right? However, it was a case of rectal bleeding, right? So that's when we shifted from screening to more diagnostic, and that's where the colonoscopy was more appropriate. So being able to identify the different types of modalities and when to use what is very important for us. Do not dismiss mild rectal bleeding, needs close follow-up. Early detection of colorectal cancer is key for treatment options and survival. Taking a very thorough family history is key wherever possible. Colorectal cancer incidence is increasing in young adults, even without clear risk factors. So we have to be vigilant to try to make an early diagnosis. And then very importantly, partnering with our colleagues, our GI specialist, our oncology specialist, especially when there's ambiguity or we have any suspicion for red flags is very important. Taking a team-based approach is key for our patient care. With that, I'd like to open up to our specialist colleagues. Is there any other final thoughts or wisdom pearls that you would like to share?
Thanks, Pia. I think you really hit the nail on the head there in terms of this is a collaboration between multiple different groups. And I think communication between the patients and their providers is so important, but the communication between the different providers from different specialty groups is just as important. And building that relationship, increasing the education, not only among our medical community, but going out there and meeting our patients where they're at, understanding where their barriers are, hearing from them, meeting with community stakeholders. I think that is so important to understand, what truly are the challenges that our patients are facing, and hearing from their voices can really help us as well, not only with the barriers that we know about, but those that we may not know, and also to help the disparity in care that we see as well.
You're preaching to the choir. I echo everything that you say.
I just want to remind attendees you can enter questions in the Q&A as we continue to have a discussion amongst our panelists. Tracy, I didn't know, Dr. Battaglia, I didn't know if you had any questions. You have a huge interest in disparity in cancer screening. What are some of the questions that you had?
Yeah, I mean, I think that, first of all, thank you for that wonderful discussion and dialogue. And I think fear is my first emotion that I'm having in listening to this presentation for two reasons. Two of the cases that you presented, common things are common in young people, right? And so, constipation and rectal bleeding one time, like what does close follow-up mean, and how much do we tolerate clinically before we sort of pull the trigger on a diagnostic test? And similarly, in a young menstruating female who has IBS, like, wow, like, can you just speak a little bit more about that? Because I think this is our worst nightmare as a primary care physician, is missing something like this. But yet every day in our practices, we're hearing these kinds of symptoms.
I'll just say, when we had iron deficiency anemia, being a premenopausal woman was like a get out of jail free card, right? That meant you did not need to investigate colorectal source of blood loss. And it's just no longer true.
Mm-hmm.
I think our threshold has gone down dramatically, responding precisely to that, and we should. We could be extremely sensitive and overload our system, but a close follow-up and things that are not that clear, a very close follow-up, and whenever we don't feel comfortable, just going ahead with the diagnostic test for sure. I think we all have responded to that, and probably we just have to be more sensitive, because what Thejal was saying. I mean, everyone born after 1960 has a much higher risk of not only colon but other cancers. So we can approach things business as usual. We have to be much more vigilant and more aggressive, to tell you the truth, with symptoms.
Yeah, and then I was just thinking, for that third case, would we want to get like a serial H&H? Like, how frequent would we check the hemoglobin there?
Yeah, I mean, I think it really depends on the context, but exactly what we have been discussing, if there's anything that is persisting or anything that's not just doesn't feel right, if they aren't responding the way that you'd expect them to, I think there should be a very low threshold to just ask, to just get checked out. And of course, that's much easier said than done for the reasons that we've already discussed as well, in terms of systems limitations and provider limitations and all the barriers there are to get care in the first place. But I think that's when, again, the communication between providers can be very, very helpful.
You make a great point there, Thejal. I'm just thinking back to another case I had earlier last week where I didn't formally consult oncology, but just having a relationship with one of our hem-oncologists in Greenwich Hospital, Dr. Montanari, I was able to do like a soft consult and come up with a strategy. And then we ended up going a different route than going straight to hem-oncology to make it more effective for the patient. So just to summarize our relationships, collaborating with our colleagues, it's so important. It's an investment for patient care, right? To give better patient care.
I wonder if I can follow up on that sort of this line of sort of discussion, and it relates to sort of like how long is too long to like wait in terms of delay. And we know that access in our system across the country is far from perfect. And sometimes we have to advocate as primary care physicians to make sure that colonoscopy gets prioritized or that consultation, with whatever specialty gets prioritized. And unfortunately, we don't necessarily have safety net systems in all of our practices to be sort of managing all of that. And so, is it like a 3-month mark? Like that was just unacceptable? Or, I mean, obviously I understand your index of suspicion is going to sort of dictate that, but like in that case for that young woman, should have stage 3, is that right?
Yes.
So
right.
like, was there a long delay in her diagnostic workup?
I mean, that probably developed over the course of months. And I would say, although she might have had a precancerous lesion over a year or more
Right.
than that. So I think it's truly challenging. And I think this is where I'm really excited about the developing technology to see what can we take, have as a pressure release valve from our system. Can we transition some of these really time and resource intensive screening methodologies to things that are more accessible? And can that improve equity in the care, not only in terms of access, but actually delivery as well? But we're not there yet. Dr. Llor, do you have thoughts?
Well, it just comes up to my mind right away at the screening level, how our data nationwide in terms of follow-up colonoscopy after a positive stool-based test, which is about 60% over a year. So that's not good.
No.
That has a lot to do because for a lot of reasons, one of them is that we have not fully developed a system that prioritizes things appropriately. And if we do have a positive stool test, that's not no longer an elective thing. That's something that needs to happen within 6 months. And the 6 months is no soft number. Is that we know that really after 6 and more after 9 months, prognosis does change. Therefore, this is something you have to deal with. And I think it does call for that system-wide reorganization and calling more on really risk stratifying. If we have a low risk person, maybe those were the people who can benefit the most from the non-aggressive screening options, and then make sure that we have the availability for all these positive stool tests and for everyone who's at higher than average risk. So I think it does take us to think in a more global way. As we were talking about, as Thejal was talking to us about the early onset cases, we can't just work on silos here because the needs of our patients are much more complex than that. And so we need to understand capacity and our availability to really make sense of it, to care for patients in the most proper way, and not everyone getting the same thing, because not everyone is going to benefit the same way if we give them the same things.
Yeah, there's two key things, Xavier, from having participated in other talks with you. I mean, it's really clear that having a system for cancer screening, right? It's not just whether they're behind closed doors with any one clinician. The whole organization works on a system for making sure that people get screened, and then adding in risk stratification, for most proper use of resources, I think is really good. And we have drawn to the end of our hour. We almost went over because this was pretty interesting and incredibly well presented. So thank you so much to each of our panelists for all of your words of wisdom to us tonight. And thank you, Tracy, for co-hosting with me. And thank you, everybody who attended or who is watching this later.
Thank you.
Thank you so much.
Bye.
Take care.